בחצי השני של מושב הבוקר שלנו יש לנו הרצאות קצת יותר קצרות, וההרצאה הראשונה היא תינתן על ידי פרופסור רמית רבונה, עמיתה שלי מבית החולים שיבא ברמת גן, ופרופסור רבונה היא פסיכיאטרית גריאטרית, פסיכיאטרית של הגיל הזקן, והיא מנהלת את המרפאה לדמנציה בבית החולים שיבא. ורמית, אני מזמינה אותך.
So it's a good thing that we had a recess, because talking after Nathan is really a big challenge and a big honor for me. So thank you. And just to stress the fact that we don't have geriatric psychiatry in Israel, and this is a big fault, and something that Nathan was talking about. We should have geriatric psychiatry. I'm just a psychiatrist, but I'm doing mainly psychiatry in older adults. So I'll be talking about neuropsychiatric symptoms as predictors of cognitive and brain-related outcomes. And these are the issues that I'm going to try and touch. First of all, what are neuropsychiatric symptoms for those of us that are not really acquainted with the field? What are the roles of neuropsychiatric symptoms? Are there early markers for neurodegeneration, or are there risk factors for neurodegeneration and dementia? And I'll touch a little bit about the effect of treatment of neuropsychiatric symptoms, although there's not a lot of literature on this subject. So what are neuropsychiatric symptoms? These include symptoms such as apathy, depression, anxiety, agitation, aggression, hallucinations, and delusions. And for all of you that treat patients with dementia this way or the other, know that these are the most difficult symptoms to treat. And neuropsychiatric symptoms are acknowledged as core symptoms of dementia. They're highly prevalent, and in patients with dementia, actually, they appear in 100% of the patients at this stage of the disease or the other. And they have a detrimental impact. That is, patients with neuropsychiatric symptoms, whether they're already demented or with mild cognitive impairment or cognitively normal, have a faster cognitive decline, faster decline in functional abilities. They have higher institutionalization rates, and they have, of course, their caregivers are overburdened. Interestingly, and what is most relevant for this presentation is that neuropsychiatric symptoms can precede cognitive decline. So NPS in the context of cognitive decline and dementia are important both as treatment targets, but also as disease markers. So I'll just say a few words of as neuropsychiatric symptoms preceding cognitive decline. In this study, based on a multi-center study in the US, the NAC study, they followed people who eventually converted to MCI, a stage considered to precede frank dementia, and dementia. And what they saw is that in 55% of the people who eventually developed mild cognitive impairment, and 67% of those who eventually developed dementia, the neuropsychiatric symptoms preceded cognitive decline. And if we look at the data from another angle, so if you look at patients that have MCI, we can see a conversion rate to dementia of about 10 to 15%. This is quite acceptable depending on the cohort study. But if they have MCI and neuropsychiatric symptoms, then this doubles the risk for a conversion to dementia, and there is a 25% conversion rate per year. So the acknowledgement of the importance of neuropsychiatric symptoms as preceding dementia or mild cognitive impairment is reflected in the concept of mild behavioral impairment. Mild behavioral impairment reflects a state in which there are newly emergent behavioral symptoms or personality changes over the age of 50, and importantly, these must be persistent changes, that is at least 6 months. These can be in several dimensions of behavior, that is decreasing motivation, for example, apathy or aspontaneity, ineffective dysregulation in the form of anxiety or dysphoria, impulse discontrol in the form of agitation or disinhibition, social inappropriateness in the form of lack of empathy or loss of social graces, and also abnormal perception of thought, that is psychosis. These symptoms might be sufficient to produce some impairment in social interactions at work, but grosso modo, the people are independent, okay? They can carry on and they don't need help in their daily life. And these symptoms are not attributable to another psychiatric disease, okay? That you can't diagnose MBI in the presence of schizophrenia or major depression. And of course, cannot be attributed to a traumatic brain injury or medical causes and so on. And people do not have dementia. If you're already demented, it's not MBI. So you see Nathan here. So in this study, following people from the NAC study who had mild behavioral impairment, you can see that the presence of mild behavioral impairment is associated with an increased risk for development of clinically diagnosed Alzheimer's disease, but also pathologically diagnosed Alzheimer's disease. And the increased risk is relevant for all dimensions of mild behavioral impairment, particularly for psychosis, but for all dimensions, for apathy, for affective dysregulation, and so on. So they are important markers. And why is this subject so relevant today? So today we have 2 approved, FDA-approved medications for the treatment of Alzheimer's disease, 2 disease-modifying treatments. So if we could detect people that could be candidates for these treatments earlier than they present with cognitive symptoms, maybe we could present the treatments earlier and thereby have a higher advantage of the treatments. Also, there is increasing acknowledgement of behavioral symptoms, some of the behavioral symptoms, as risk factors for modifiable risk factors for dementia. So if we treat these risk factors earlier, perhaps we can prevent dementia. So either if we treat them as risk factors or as markers of disease, we can intervene and perhaps present some advantages. But of course, the approach will differ depending on how we conceptualize neuropsychiatric symptoms. These are draft guidelines of the FDA for the development of disease-modifying drugs for Alzheimer's disease, in which they write as follows. It is highly desirable to intervene as early as possible in Alzheimer's disease, making individuals in stages 1 and 2, which are currently not treated by disease-modifying drugs, okay, they're too early for disease-modifying drugs, and 3, which are the ones already treated, that is MCI due to AD, high priority candidates for disease-modifying trials. So maybe the next trials are going to be in people with MBI, and we'll see how we can, what is the association between MBI and biomarkers of the disease. Another example for why it is so important to intervene so early. This is a study performed at the University of Washington in which they looked at individuals that would be eligible for disease-modifying drugs for Alzheimer's disease in terms of amyloid positivity and cognitive status. And they modeled the rate of deterioration in their instrumental activities of daily living and basic activities of daily living, and asked the following question: what is the association between how early we start treatment and how many months of independent activities in instrumental activities of daily living it would give us? And what they saw is that if someone is very, very early, right, they only have difficulty in remembering dates and medications, then intervening with disease-modifying drugs at this stage would provide them additional 10 to 13 additional months of independence in activities of daily living. But if you start a little bit earlier, difficulty in remembering dates and medication, paying bills and driving, then that would provide only 4 to 5 additional months of independence in activities of daily living. So I'm asking the question, if we intervene even earlier, when they don't have any functional decline, when they don't have any cognitive symptoms, mainly based on mild behavioral impairment or neuropsychiatric symptoms, could we give them, provide them additional months of independence in activities of daily living? So let's talk a little bit about the roles of neuropsychiatric symptoms of early markers of disease, particularly Alzheimer's disease. So we know that Alzheimer's disease is a biological process, and the biomarkers that reflect the neuropathology of the disease are present before cognitive symptoms appear. Okay, they start with amyloid pathology and followed by the classic model is amyloid pathology and tau pathology and then neurodegeneration and only then cognitive decline, which grows to be severe enough for MCI and dementia. Now, today we have biomarkers reflecting these changes, biomarkers in the CSF, biomarkers in blood, and in various forms of neuroimaging. So if we were to use neuropsychiatric symptoms as disease markers, they will have to be to reliably indicate the presence, severity, and progression of Alzheimer's disease pathology, and would also have to predict or be associated with disease, with cognitive outcomes. So I would like to be able to tell you, at least in a very general manner, that mild behavioral impairment or neuropsychiatric symptoms are closely associated with Alzheimer's disease pathology, and that they predict a more rapid progression to cognitive decline and dementia. And let me prove you what I wrote here. So in this study, following almost 800 cognitively unimpaired individuals, non-demented individuals, the majority cognitively unimpaired, and some of them with MCI, with ages of 50 and above, who underwent CSF analysis. They showed that in older adults free of dementia, lower CSF A-beta 42 and T-tau A-beta 42 ratios and P-tau, total tau and P-tau A-beta 42 ratios were cross-sectionally associated with neuropsychiatric symptoms. That is, neuropsychiatric symptoms in non-demented individuals are associated with Alzheimer's disease pathology. So this was about CSF biomarkers. What about blood biomarkers? In this study, looking at ADNI participants, this is one of the largest studies following older adults with or without dementia. They looked at participants with normal cognition, and what they saw that mild behavioral impairment. You remember when I told you what is the definition of mild behavioral impairment? You have to have neuropsychiatric symptoms that are newly emergent, and they have to be persistent, at least 6 months, okay? So mild behavioral impairment, but not neuropsychiatric symptoms that are not MBI, particularly on the basis of their duration, link with higher plasma phospho-tau 181 and increase over time in p-tau 181, with decrease in episodic memory and executive function, with lower dementia-free survival and almost 4 times greater risk for Alzheimer's disease dementia. Okay, so here I showed you that there is an interaction with, there is an association with CSF biomarkers, now with the blood biomarkers. And this is also relevant for p-tau 217, which is one of the strongest predictors of dementia. Okay, this is also in dementia-free ADNI participants. And in addition to showing that people with MBI have higher levels of p-tau 217, what is very interesting is that neuropsychiatric symptoms were stronger predictors of p-tau 217 levels compared to age, sex, education, and even MCI diagnosis. That is very strong predictors for neuropathology. We talked about fluid biomarkers, CSF and blood. How about neuropathology? So in these studies, they look at the association of, in the triad cohort, the translational biomarkers for aging and dementia cohort, which followed people with normal cognition, MCI, and dementia. And they look at the association of neuropsychiatric symptom severity and Braak stages, which is a system for staging of Alzheimer's disease based on the severity and location of tau pathology. And what they see is that PEST-based Braak staging correlates with neuropsychiatric burden and severity, and with the increase over time in neuropsychiatric symptoms. This is another study looking at the association of neuropsychiatric symptoms that's in the form of mild behavioral impairment and brain atrophy. This is in almost 1,400 dementia-free participants of the NUC study. And what they categorized participants to three groups: those with no neuropsychiatric symptoms, those with neuropsychiatric symptoms but are not severe enough to be diagnosed with mild behavioral impairment, and those with mild behavioral impairment. And what they saw is that MBI was correlated with decreased brain volume in all the regions of interest, that is the hippocampus, the entorhinal cortex, and overall brain volume. Whereas neuropsychiatric symptoms that are not severe enough to be diagnosed with MBI are only associated with lower volume of the hippocampus in cognitively normal participants. In the same study, they also showed that mild behavioral impairment compared to those without neuropsychiatric symptoms has the highest rate of cognitive decline over time and the highest risk for development of development of dementia, and that people with neuropsychiatric symptoms short of the definition of MBI are intermediate between normal controls and those with MBI. So I hope that I have brought enough evidence to show that neuropsychiatric symptoms correlate with Alzheimer's disease biomarkers, with amyloid pathology, tau pathology, and neurodegeneration, both in biofluids and in imaging, and that also that neuropsychiatric symptoms correlate with cognitive outcomes. Now, what if we look at neuropsychiatric symptoms as risk factors, not as markers of disease, but as risk factors? So I think there's not enough data on this subject, and the data out there is mainly relates to depression. So depression, as Professor Herman said before, depression is linked to at least twice the risk, higher the risk of dementia. And look at these numbers. The elimination of depression is expected to reduce 4% of dementia cases. This is in comparison to 2% if you modify hypertension, 0.5% if you modify diabetes, 0.8% if you modify obesity, and 2.6% if you modify physical inactivity. So this does have a significant contribution to prevention of dementia. Now the question is, which type of depression and what is the time in life in which depression is the highest risk for dementia? So in old age, although old age depression is consistently associated with a higher risk for dementia, there is a big question about the directionality of these associations. Is depression a risk factor for dementia, or is it the presenting symptom of dementia? So acknowledging this complexity, the Lancet Commission for Dementia Prevention and Care acknowledge midlife depression rather than late-life depression as a risk factor as a modifiable risk factor for dementia. So this is reflected, for example, in a study looking at participants of the UK Biobank, age 50 to 70. There were more 350,000 patients followed for more than 20 years. And what they see is that the risk of dementia is associated with depression, right? Those are those without depression, and those in blue are those with depression, and clearly those with depression are at higher risk. But also, it's not only the fact that they had depression, but the trajectory of depression over time, okay? The trajectory at highest risk for developing dementia was those with increasing symptoms of dementia. Those with decreasing symptoms were similar to those without depression, whereas those with chronically high or chronically low depression were intermediate. Also, and this is important if we see depression as a modifiable risk factor for depression, what is the effect of treatment? So when they look at people treated for their depression versus those that were not treated, we can see that those who were not treated had higher rates of converting to dementia over time. And they also looked at what type of treatment. So those that were more best protected were those that received both pharmacotherapy and psychotherapy, and whereas the other combinations, only psychotherapy or only pharmacotherapy, were protected but to a lower extent. Of course, there are many questions to be asked here. This is a naturalistic study, so who are those that receive both psychotherapy and pharmacotherapy? There are many questions to be asked, but it is a signal that treatment of depression has a beneficial effect for prevention or postponement of dementia. So in summary, neuropsychiatric symptoms are markers of Alzheimer's disease pathology and of poor cognitive outcomes, and their measurement may improve early identification of individuals at early stages of the disease. Some neuropsychiatric symptoms are also risk factor for dementia, and we know this mainly about depression, and their treatment may reduce incident dementia. And I hope that if we're in an era that we also screen for behavioral symptoms, not necessarily those that are severe enough to be hospitalized in a psychiatric ward, yeah? If we screen them, then we can introduce both early prevention and maybe identify those that are good for disease-modifying treatments. There are numerous remaining questions. I'll just state some of them. Most research on the role of neuropsychiatric symptoms in prediction of dementia are carried out in older adults, whereas midlife is the most important time in life for introduction of prevention. Research on specific neuropsychiatric symptoms is relatively scarce. You see in most of the studies that I presented that they look at the total score of NBI or total neuropsychiatric symptom score. They did not look at specific symptoms. What is the effect of treatment of neuropsychiatric symptoms? This is a big question. And of course, there are numerous methodological issues. For example, what are the cutoff scores in scales that we should look at? Should we look at informant-reported neuropsychiatric symptoms or self-reported? What about development of objective measurement of behavior? What are the optimal measurement tools? And what is the association with biomarkers that are not specific for Alzheimer's disease? I showed you only associations with markers that are specific for Alzheimer's disease. So this is how I feel now. Thank you.